They are basing their self-worth mainly on their body weight and shape. And that's actually typical of most eating disorders.
Hello and welcome. I'm your host, Severine, and today we have a truly special guest with us, Anne Richardson, a dedicated nutritional therapist who specializes in eating disorders. But before we dive into our conversation with Anne, let's take a moment to reflect on some eye-opening statistics surrounding eating disorders. Over the last 4 decades, there has been an increased number of individuals struggling with eating disorders, not just in the UK, but on a global scale. Astonishingly, 2 years ago, post-lockdowns, the NHS reported an 84% surge in hospital admissions for eating disorders in just 5 years, particularly impacting children and men. Here in the UK, between 1.2 and 3.4 million people are currently facing the challenges of an eating disorder, with a higher prevalence among individuals aged 16 to 40. Strikingly, 19% of women and 13% of men over the age of 16 are exhibiting signs that suggest a potential eating disorder. However, in the spirit of optimism, it's crucial to know that early intervention significantly enhances the chances of recovery. Now, let's turn our attention to our esteemed guest, Anne, whose dedication to addressing eating disorders is truly commendable. Anne, thank you for joining us today. We're eager to explore your insights and expertise on this important topic. To our listeners, get ready for an enlightening conversation that promises to shed light on a subject that touches many lives. So without further ado, let's jump into this meaningful discussion.
Thank you for having me.
Anne, for those who may not be familiar with your incredible work, could you kindly share a bit about yourself?
I'm Anne Richardson. I'm a registered nutritional therapist, and I exclusively work with people with eating disorders or with disordered eating.
Actually, what inspired you to focus your expertise on this crucial and compassionate field of eating disorders?
Okay, I'll try to make it brief because I could go on for ages, but I guess the long and short of it is that I had anorexia when I was probably about 16. I got better. I'm one of the, the lucky ones really who, got better quite naturally. It did last for quite a few years, but I got better. And then, I went to university. I moved to the UK and I worked and I got married and, I had children. Amongst all that, towards the end of my 20s, I had what I call a quarter life crisis, and I decided to ditch my job basically in publishing and retrain and work in the field of nutrition. And it honestly had nothing to do with eating disorders. I was not interested in working with people with eating disorders or like weight loss. It was just not on my radar. I didn't want to go anywhere near that. In fact, I'm pretty sure one of my tutor when I was studying asked if anyone wanted to work with eating disorders, and I said no. It wasn't something I wanted to go back to. But as I started practicing, I could see a lot of people were coming to me with weird habits when it came to food, and they really reminded me of things that I used to do when I was ill. And I thought, oh, hang on a minute, that there's something not quite right. And, we had been trained, it had been drilled into us that we couldn't work with people with eating disorders without training. So I went off and did some training. And then very quickly, I was just inundated by people. And then I decided to only see those people. It wasn't my life plan. And it wasn't like my vocation because I had recovered. It wasn't really like that. It kind of found me. So, but yeah, that's what I do now.
Yeah, that's amazing. And for those who might not be familiar with the various types of eating disorder, could you provide us with an overview and delve into perhaps the main ones? I know just what, the media say about it, but yeah. I know sometimes the media, they portray something completely wrong. So it's best for the specialist to actually give us a better explanation and definition of what is.
Well, I guess the first thing to say is that there are lots of different eating disorders. Usually when we say eating disorders, people just think anorexia. And, that's one, but there are lots of other ones. There are the main ones would be anorexia nervosa, bulimia nervosa. You have binge eating disorder, and you have OSFED, and amongst OSFED you've got other subcategories. So I'll just briefly describe them all. Anorexia nervosa is when someone restricts their food intake drastically so that they lose a significant amount of weight for their age, development developmental trajectory or for their genders. It's not like, oh, your BMI is low, you have anorexia nervosa. It's not just like that. It's you have to take into consideration the whole person, so the age, gender, etc. And also you have to look at why that is that they've lost so much weight. Typically someone who is undergoing like cancer treatment might lose quite a lot of weight. It doesn't mean they've got anorexia nervosa. They can actually develop anorexia nervosa from then, but for it to be anorexia nervosa, you would have to have really importance to body weight and shape in regards to self-worth. So essentially, they are basing their self-worth mainly on their body weight and shape. And that's actually typical of most eating disorders. So with bulimia, you also have this. They are also basing their self-worth on their appearance. And they tend to also restrict their food intake, but they may or may not be underweight clinically. And that's because aside from restriction, they also have episodes of binging. And by binging, we mean eating an objectively large amount of food in a quite short period of time. It's not like eating a packet of biscuits. I'm pretty sure we've all done that at some point. That's not necessarily a binge. There are sort of criteria to a binge. And then what happens with bulimia is that people feel terrible because obviously they base their self-worth on their shape and appearance, and they think, oh my goodness, I've eaten all of this food, it might affect me. So then they compensate either by self-induced vomiting or using laxatives or medications, or they would also exercise compulsively. So there is this compensation that happens. And with binge eating disorder, it's actually very similar to bulimia. And the shape and weight is also really important, even though those people tend to be normal weight or overweight. So you think, oh, clearly they don't care, but actually they do care a lot, and they actually restrict also. And because of that restriction, they also tend to binge. But unlike bulimia, they don't compensate for the food eaten for various reasons, and so that would be more classified as binge eating disorder. The OSFED is otherwise specified feeding and eating disorder, which I always think it sounds quite made up and it sounds like not real. So I always feel sorry for people who get diagnosed this, because it sounds like it's not like a proper eating disorder. You haven't tried enough, basically, which is not the case. It's actually a melting pot of eating disorders which don't fit neatly the criteria of anorexia, bulimia, or binge eating disorder, but it's not quite right. So this would be classified under OSFED, and you have different types of eating disorder under OSFED, but there's quite a lot of them. So I can't go into all of them. But the main point you get from this is that if you have been diagnosed with OSFED, it doesn't mean you're not sick enough. It just means that it's slightly different to the other sort of like more classical eating disorder that I mentioned before. And also bear in mind that before, I'm pretty sure that binge eating disorder wasn't in the criteria originally. Things changed. So who knows what it's going to be like in, 15, 20 years time. So that's the important bit to remember.
Thank you for a big clarification. And you've mentioned a few times that there are criteria, there's a diagnosis. So does this diagnosis have to be done by a professional, or can people self-diagnose with this kind of disorders?
I think if you want an official diagnosis, it needs to be done by professionals, so like a GP. I think psychologists can also diagnose. I can't diagnose. So yes, professional would have to diagnose, but at the same time, you don't need a diagnosis to be ill. I see lots of people who have come to me without a diagnosis. I therefore don't say, oh, you have bulimia nervosa, but I will help them in getting better in terms of their eating. I don't think I was diagnosed, but I'm pretty sure that had I gone to someone, I would have been diagnosed with anorexia nervosa. That's kind of what it was, really. But I just didn't have that stamp there.
Yeah, because there are like some common symptoms that you mentioned, but also what I wanted to say is you cannot diagnose, because as a nutritional therapist, we are not authorized to diagnose any condition. We are able to help. By law, we are able to help with the condition, with the symptoms, with everything, but we cannot diagnose and we cannot treat. But it doesn't mean that our intervention is 100% favorable and brings some amazing results. So that was just a clarification. On your website, you mentioned that eating disorders often begin in childhood, as early as 6, which is I found incredibly early, but more common around the age of 9. In your opinion, do you believe that we are taking adequate measures to protect and support our children today? I'm aware of your significant work with schools. So that's why I'm asking you this question.
I guess it depends. What do you mean by we? Do you mean like we parents, we society?
By we, I meant the government, because the government is supposed to, oversee everything that is done in schools, including school meals.
It's difficult to answer, basically, your question, because you've got lots of different reasons, lots of different factors to consider. And I think the world is changing quite rapidly. So I have two children who are 11 and 14, and their world is very different to my world. And my world, I think, was bad enough. I managed to get an eating disorder as a teenager, but now our children are evolving in a world that is very visual, very digital. You can have a child that you think is safe at home, but actually they are on their phone and watching things that aren't necessarily safe. And I don't mean like really dangerous stuff, self-harming stuff, but I mean just images that are damaging to their self-esteem that could actually propel them into an eating disorder. Now, is this the job of the government? Is this the job of the parents? That's always complicated to answer this question. I think essentially the world is evolving faster than we can cope with. And that's probably not helping our children, because we are left a little bit behind as parents, and therefore our children are probably negatively impacted by that.
I just realized that my question was exactly what you said, bringing back to my time when I was a child rather than now. We didn't have social media or mobile phone or TikTok. We couldn't compare it with each other. What we could do is like me versus my friend, and who is looking better according to my criteria. But yeah, you're right. Now there is an extra person, which is often unrealistic because it's photoshopped in any way. So yeah,
we had
obviously,
magazines though. We had,
yes.
we had Elle and Vogue, and I was looking at those things and I was thinking, why don't I look like those people?
You're right, but I was thinking more primary school children, to be honest. I should have framed the question differently, because you said it started that young, and that really shocked me. And I don't remember having watching Vogue or Elle as a child.
The TV, you can think about, you look at, let's say Strictly Come Dancing, it's a lovely family show, which I quite like, but the people there, like the hosts, they look beautiful and they look like people that I could never look like. And basically the TV is the first media, and you see people who are perfect even on TV. That's a bit tricky.
So what proactive steps would you suggest to contribute to a good development of children, preventing them, if possible, to go into the eating disorder route?
I haven't banned social media. I haven't banned phones. So it's not really about banning things, but I think it's about talking. I'm quite big on talking, and I'm big on talking about everything, and also having some limitations. My 11-year-old doesn't have Instagram. It's not happening. You need to be a certain age. He's got a phone. He can text his friends, but you need to be a certain age to have Snapchat, to have all those things. There is some kind of boundary that I put in, but also talking. So my eldest has social media now, some social media, and we talk about all sorts of things. We also I'm allowed to have a look at what he's looking at, because it's technically my phone. So at any point I could do random check in his phone, and it's not to be mean, but it's just to protect him. Once I have seen something which wasn't terrible, but it wasn't ideal, and we talked about this. I said, look, I'm not angry, but at your age it is not appropriate. So you need to do your best to sort of block that kind of content, and I will do the checks, and if that happens again, then we can discuss things. But I understand that you would be curious about that kind of stuff, but at the same time it's not appropriate. And it wasn't like horrible stuff or anything, but I think for me as a parent, that's how I deal with things. But we also talk about all sorts of things at home. We're very open, and I think for parents a really important thing is to be talk active, but also to be neutral. Children model us, so we need to be neutral when it comes to food and when it comes to our body. So I can't tell you that I always look at myself and go, my God, I look super hot. Most of the time I just go, my goodness, what's happened to me? Why do I look so old? I don't say it in front of my children. It's not something I want them to hear, because otherwise what I'm saying to them is your appearance really matters, and you need to start thinking about your appearance as well. So I try to be quite nice to myself in front of them, even though sometimes I have my doubts, but I don't voice that out. I don't go, look at my cellulite, or, I look hideous. I don't ever say things like that. They will never hear me say that because I don't think it's a good idea. And if someone in my family says something a little bit mean about someone or themselves, I will pick them up on that in a nice way, but I will say, look, that's not a kind thing to say, or we'll have a discussion about that. And I'm also very neutral about food. I know we probably have slightly different approach maybe on nutrition. In my house, you will find some ultra processed food, but we're also quite neutral in the approach to food. So I'm not saying, look, it's totally fine to just have crisps and chocolate and a jam sandwich for lunch every day. So I will explain to them about the protein and the carbohydrate, blah, blah, blah. But they had a wagon wheel today in their packed lunch. I don't really have a problem with this because I personally feel like if we ban this foods altogether, it becomes quite powerful that they are drawn to it. And I see kids, we're talking year 7, year 7, year 8, you're finally out of your parents' side, you're going off to school to take the bus, you've got a bit of pocket money. And often kids who have had none of those foods will end up going to the corner shop and they'll buy some of the food that they've never been able to have. And that's when binges can happen, actually, because there is shame in eating those foods because they've always been told it's bad. So they'd eat them quickly on the way to school, on the way back, or in their rooms and hide the evidence. And that can actually feed a cycle of shame and binging and actually weight gain and then weight loss. And it can be quite negative. So I'll just go in my house. Yeah, you've got this. No, you're not going to have a lunch of just wagon wheel. And you know what? Today, I don't think you've had a piece of fruit. So no, you're not going to have cake for pudding. You can have an apple. Tomorrow, we'll talk about it. So it's more like neutral. It's not, this is bad. It's just, hey, we do need to look after our bodies because, that's the only one we have. So a bit of fruit and veg, please. A bit of protein. Yeah. Have a chocolate bar. Whatever.
I actually have exactly the same approach as you.
Okay.
Because
Good.
I know exactly what it is to be restricted and then go completely wild whenever you can. So my son is very Haribo centric and chocolate and cakes and everything. So he has some at home. He actually has a special drawer with all these treats, and he learns to manage the bags and everything. So he can have some sometimes, but not like everything at once. And it works actually pretty well. And I realized it worked really well, with Halloween. He had like a whole bucket of lolly sweets and everything. And it took him a year to finish it.
Wow.
And I'm like, wow, I did a really great job because I didn't say, no, you can't have any or I'm going to confiscate. It's just like, we're keeping that and we're eating it a bit at a time. So I am just like you, he has to have his proteins and his veg and fibers and all that. But yeah, he's also allowed to enjoy and know what else there is. Otherwise, the curiosity will be really bad at some point. So
yeah,
we definitely have the same approach. So now let's assume that someone has an eating disorder. You explained there are different types. Are they all typically of the same duration, or does it depend on which type?
I think it depends more on the person and on the onset. I don't think there is like a set answer for that. I think really the earliest it's caught, the shorter it's likely to be. If you catch it after 20 years, recovery is going to take quite a bit longer.
They usually start in childhood or in teenage years. Do they progress in a certain way as in adulthood, or does it start and stays the same for a while?
Just wanted to caveat things. It doesn't always start in childhood, but it often like the first seed is planted there. And when I say it can start as early as 6, usually it's the thought that's there. It's all, you know what, my tummy looks a bit big. They might not necessarily do anything about it. And then it tends to sort of like evolve. I would have said 13 before. Now it's more actually like 11, 12. I mean, it depends on the person. So it's not always starting in childhood. And I've seen people for whom it started during the menopause. I'll answer your question in a second, but essentially eating disorders love a transition. So puberty is a big one. So that's why it often happens. And especially because puberty, you have a change of your appearance. So it's quite a big one. Hence why it's quite common at puberty. But it could also be starting university. It could also be your children having flown the nest. It could be the menopause. It could be pregnancy or giving birth. It could be after an accident. essentially transitions are key, I think, to me. And then to answer your question, it's quite common that someone ends up with different types of eating disorders. It's not like you get one, like you catch the flu and that's what you have. It's not a virus. It's likely that it will morph, and it's not the case for everyone. I've only ever had anorexia, partly because I couldn't actually make myself sick. I tried, but it didn't really work. I might have ended up with bulimia had I managed, but because I didn't, I just stuck to that. But it's quite common that people have several eating disorders. So sometimes it's anorexia and then bulimia, anorexia, orthorexia, or bulimia, anorexia, bulimia, binge eating disorder. You could even have binge eating disorder and anorexia. There is no real pattern. You can go either way, and you can have not quite all of the eating disorders because there are quite a few, but it's quite common that someone will have several. And obviously the longer it lasts, the more likely you are to have different, because just of the time period, different eating disorders, that is.
That makes sense. Once someone realizes they have this condition, is there a catalyst that prompts them to seek help to overcome their eating disorder, basically?
Yes, scenarios. So I see a lot of teenagers, and the catalyst for seeking help is usually their parent, which isn't ideal because often I am faced with a teenager who doesn't actually want to get better. Not because they are bad people or anything, it's just that they are still comfortable in the eating disorder and they want to stay there. But the reason why they've come to see me is because their parents has sent them. And that makes my job quite difficult, because it's difficult to work with someone who doesn't want to work with you. But, that's by the way. Let's say someone comes to me because they want to get better. Usually the catalyst is essentially the cost of the eating disorder has become greater than the fear of recovery. They don't want to do this anymore. I personally think that for me, that was the case. I just had enough. I didn't want to do this anymore. It was too tiring, too much, too many sacrifices, and I needed to change.
So what kind of supports are currently accessible for people who want to deal with their eating disorders?
It depends how old you are and where you are in the UK. I think if you are younger, you are more likely to get help. If you are very underweight, you're more likely to get help, which is wrong, but that is the way it is. I mean, it's right because to an extent, if you are really underweight, potentially your life is at risk. So of course, it's right that you get help. But someone who isn't underweight could wait for quite a long time, even though they are actually really ill, and that's wrong. If you're a man, statistically, I think you're going to wait longer. There's still this belief that it's a female thing, and so men and boys are less likely to get diagnosed. So you're going to wait a bit longer, and it's more likely that people will brush things off, going, "Oh, he's just going through a phase. He's just a bit picky." Well, actually, he's really ill. And I find as well, because I see people from all over the UK mostly, where you are will have an impact on how quickly you're going to get help. So it depends on services, it depends on local authorities, and it depends on availability. I've had people who were seen literally like straight away, and I've heard people who were told, you will need to wait a couple of years, and that was someone who was underweight.
In your view, what are the primary challenges confronting the field of the treatment?
Costs. Basically, there needs to be more money available for treatment for people. I don't think there are enough services and therefore staff. And even if we're talking about inpatient units, they don't seem to have enough beds, and it's not really their fault. They can only have so many beds. But I know locally, they only have 12 beds. That's not a lot, and they can't do much about that, but they don't have the funds for any more.
And what would you identify as the key components for a successful treatment?
I would say a multidisciplinary team. There needs to be someone who oversees the medical side of things. So typically I will contact the person's GP, especially when weight is an issue and that the person is underweight or needs to regain weight. There needs to be like regular weight monitoring, and it's important to make sure the person isn't losing weight, especially as I often work remotely with people. I need someone on the ground seeing that person. There needs to be some psychological support, because I'm sure you've heard about this. An eating disorder is about the food, but it's not really about the food. Originally, there was something there that the person couldn't really deal with or was finding distressing, and they needed to cope with that thing, whatever that thing was. And food became the way to cope, and not food, or the control of food became their way of coping. And the problem with that is that food then becomes a problem in itself. So you end up having two problems. You have a psychological problem that the psychologist needs to deal with, and then you have a food problem, and then that would be sort of my job, or someone like me, or dietitian, or someone like that, dealing with that problem.
Now, you as a nutritional therapist, how does your approach differ when working with someone with an eating disorder compared to a standard nutritional therapy session?
It is literally completely different. It's like Earth and Mars. So, and it's difficult because people, and sometimes nutritional therapists don't quite get that. They just go, well, I'll be able to muddle through. It's literally not comparable. So, yeah, it's very different.
But I believe you're not just a nutritional therapist. You've got some kind of a bachelor degree in psychology or diploma in psychology.
No, I don't have a degree in psychology. I'm actually doing a CBT diploma, so cognitive behavioral therapy. And obviously I trained in eating disorders. So I have my nutritional therapy diploma, like you, and then I underwent further training in eating disorders to be able to work with those kinds of people. And since I think 2001, I've been doing a diploma in CBT. And it's not to become a CBT therapist on its own. It's really to help my clients better, because I just said, it's so different. It's like Earth and Mars. It's not like I can say to someone, look, actually fat is really good for you. You really need it for your brain. So, once you know that, that's it. Off you go and put some fat on your potatoes. That is just not going to work. And so I need a different approach. And my approach is a CBT kind of approach. So we look at things very differently. But I'm not a psychologist at all. That's why someone has to have a psychologist on board. I'm just looking at food in a more psychological way, but I'm not a psychologist.
You're helping to reintroduce a variety of food and you're coaching them in that sense.
Yeah, depending on the person, we will work on like weight restoration. I work with a lot of anorexic clients, so usually weight restoration comes into it. But yesterday I talked to someone who might become a client, and the girl is not underweight, so we don't need to restore her weight because she's already at a healthy weight. So it doesn't always happen. So I will do that, but then we will then talk about what people think is healthy eating. Often people come to me and they know a lot about nutrition. That's another difference maybe with traditional nutritional therapy. They know everything about nutrition, and then we sort of look at what they know and what is the truth really. So we sort of compare my healthy eating with their healthy eating and see how it clashes or how it doesn't fit. And then we'll talk about like myths. They have a lot of myths that they hold at the moment with teenagers. A lot of myths around carbohydrates, a lot of things about insulin and things like that. So my job is to sort of clarify things. We will talk about body image, which is not necessarily something that you would talk about in traditional nutritional therapy sessions. We will talk about exercise. That will come into it quite often, and to have a more balanced view on exercise. We will talk about their identity and how to reclaim their voice. Often with an eating disorder, it's almost like you can always view it as a parasite. It comes into you and it kind of eats you up, and you've become less and less you. And so part of recovery is once you are better, once you eat better and you are weight restored, is to sort of reclaim that kind of you-ness, what makes you you. And with teenagers, it's even more complicated because as a teenager, you're already trying to find out who you are. So it's trying to find out who you are without that eating disorder, and then reclaiming your voice, kind of saying, this is what I want, this is what, I stand for. That's the kind of thing that we would do. But that's really towards the end of the sessions. At the beginning is very much like food. We'll do a lot of exposure. Let's say, taking the example of butter that I mentioned earlier, if someone is really scared of butter, we're going to clearly talk about butter. We're going to talk about fat in general. We're going to kind of play with butter. How can we add it? How much can we add of the butter, and how often, and on what? And believe it or not, I can talk for an hour about putting butter on your potatoes. I think last week I talked for an hour about half a banana. It's like micro steps that we're making. And was in a regular nutritional therapy session, you'll go, hey, bananas are great for potassium, have one. I mean, it's not that simple, but we give facts. Whereas here, I'm not necessarily giving facts. I'm presenting facts to someone who is terrified of the facts.
And so that's your recovery method, the 8 pillar you've just mentioned.
Yeah, and it's a method. It's not like I've got a blueprint and then I will apply it to everyone and then everyone will just get better. It's like a framework, and they overlap, but there is some kind of normal trajectory. You don't start with reclaiming your voice. You have to kind of have a structure in place the diet needs to be relatively sound before you do that. The weight needs to be restored before we do that, because cognitively the person isn't going to be able to do that if they are under eating. So we spend quite a lot of time on just the food, and how much time really depends on the person. I was talking to someone yesterday, and we're kind of at the halfway point, and we have advanced very slowly with her. And it's not because she's doing badly at all, but it's because she needed to go slowly. So I said to her, look, this is where we are. Is this going too slowly? Is this going too fast for you? And she said, I think that's about right. But, from an outsider's point of view, you might just think, crikey, you haven't moved that much, because, you've been having almost the same breakfast quite a few weeks. But actually, yesterday we agreed to put in a different bowl. And that was major. Depends on the person, really.
We always have to compare ourselves to our previous selves rather than someone else. And also your clients are people who have like years of issues. So you can't just change things overnight. That's something to keep into consideration.
Absolutely. And that's why early intervention is so important, because if someone comes to me and they're 15 and they've been restricting for 6 months, clearly it's going to be easier and quicker than someone who has been restricting, like I've seen once, for 55 years.
I'd like now to touch on something that I found more on a nutritional level. I found that these eating disorders have a common issue, which is related to electrolyte imbalance. Do you agree with my findings? You don't do testing at all?
No, I don't do testing. And I know there is a school of thought for that. And I know there is like a very famous professor who is really in favor of that school of thought. And I know people talk about zinc a lot. I'm not going to say that it's not a thing, but it's not really my experience. I don't do testing because most of the people that I see tend to undereat, and so I don't need them to spend money on a test, because I can clearly see that they basically need everything. So it's not really necessary. I don't really work with supplements that much. I mean, there is a space, I think, for omega-3s, cognitively, I think it's not a bad call. Probiotics, I do use quite a bit because a lot of my clients have digestive issues. Sometimes I might use digestive enzymes, but less and less. The only thing that I might use is B vitamins, like B1 and B6. For me, these are quite important. And the reason for this is the people who have restricted for quite a long time, when they start eating again, their metabolism increases very quickly. And when that happens, they use up a lot of these vitamins, which are essential for the mitochondria. And so quickly they can become depleted. So I think there is a role for them. I don't supplement in zinc. And I know some people have said that zinc deficiency can lead to anorexia. I'm not a scientist, so I don't know.
Is it not just anorexia, not anorexia nervosa, which are like two different conditions? Because you made it clear that eating disorders have to do with how we see ourselves, not necessarily what we choose to eat. Which I understand that anorexia is like when you don't want to eat, but I don't think it's linked to something else. Or maybe that's my misunderstanding of the issue.
Oh, I see. Yeah, I mean, you can have like morning anorexia when you don't want to eat, but I think there we're kind of like, what I deal with is always like the mental health. So it's always people who come to me are always unwilling to eat because they are scared of the impact it will have on their body shape. So that's mostly what I deal with. Say that we're using supplements is going to sort of address that. I am dubious because often it's a bit more complex, because like I said earlier, it usually started with something else. And so it's that something else that we need to look at, not necessarily the supplements. And the reason why I don't use supplements is there is also a risk that the person just goes, well, actually, if I can get better with just supplements, why would I bother with just the food thing? And then you're in kind of like troubled waters if you go there. There might be a role for supplements there, more than I use, but that's kind of my approach.
I'm 100% with you with the supplements. It's just like when you hint that a supplement could help massively on their symptoms, they tend not to do the hard work of adapting their diet or their lifestyle. They just go for the supplement and think that everything will go away. Totally understand.
And you have to take them as well. I'm really good at buying supplements, not so much now, but I've been quite good in the past at buying supplements and just looking at them.
Compliance is also part of an issue to get results with the supplements. So now, how can one gently recognize signs of an eating disorders? Are there specific signs or symptoms or thoughts to be mindful of?
I guess in yourself, if you find that you're always thinking about food, what am I going to eat next? What did I eat? Should I be eating this? There's a lot of should. Yeah, should and shouldn't. You shouldn't do this, or you should do that. that, or you're going to have this internal voice that will tell you that you should or shouldn't do stuff. You will think about food a lot more than normal. I mean, it's quite normal to think about food. I love food, so I might think, oh, what shall I have for dinner? Or I might think, oh, I'm a bit peckish. Often if you ask me, what did you eat, like yesterday, I don't know. I don't even know what day it is most of the time, so I don't know. But usually when you have problems with food, you know exactly what you've eaten. It's very specific.
And it's obsessing about food, as you say. It's like specific in terms of quality of food, quantity, and perhaps knowing the calories and all the contents.
A lot of body checking as well. Do I look, oh, I've eaten, I've eaten this. Do I look bigger now? Should I, is my face looking? And there's a lot of checking.
So if someone tuning into this podcast episode realizes that either for themselves or for someone they know that seeking help is necessary, what steps would you recommend they take?
I think first of all, you need to go and see your GP, your primary care provider. I think it's important. Go and see your GP because you might be in an area where you can get help really quickly. And, the NHS is there. So go and speak to your GP to see what kind of help you can get. And even if you don't get the help straight away, it's good to be on a waiting list. Even if they tell you 2 years, you may as well be on the waiting list. And you know what? If in 2 years' time they call you and you're better, then fine. But I think just get into the system. That would be my first advice. Always go and see the GP first of all.
Okay. And as we wrap up our conversation, is there anything else you would like to share or emphasize that we haven't mentioned at this point?
I guess there's quite a lot of talk at the moment about eating disorders sometimes becoming, especially anorexia, becoming terminal. You can't recover. This is your life sentence now. And I think it's quite dangerous to think that way. I have had a client who is only 17 and she was told that she would never recover. And that is, to me, that is wrong. You can actually recover from an eating disorder. You need help and you might need more help than some others, but you can absolutely recover from an eating disorder. I don't think there is anyone who's beyond help. It might take you a long time, but you can recover.
I think that's for any condition, there is always something to do, and we should never truly agree 100% with the doctors because they might have some training, but they don't know you. Lastly, where can our listeners connect with you? Where is the best way to get in touch with you? All the details will be in the show notes.
I'm most found on Instagram. That's kind of where I live. No, I'm joking. Yeah, I'm on Instagram at the Eating Disorder Nutritionist and also on my website, which is theeatingdisordernutritionist.co.uk. You can always drop me a line. I try to share as much as I can on Instagram about what I think, what I found useful.
Great, thank you. As we wrap up our conversation, I want to express my sincere appreciation to Anne for sharing her knowledge and compassion regarding eating disorders. I hope you found this conversation as enlightening as I did. Remember, awareness and understanding are powerful tools in fostering a healthier relationship with food, both for ourselves and those around us. If you or someone you know resonates with the experiences discussed today, consider taking the courageous steps of seeking support. Thank you for joining us today. Until next time, take care and be kind to yourself and others. Thank you, Anne.
Thank you.